All right, let's dive right in. We tend to separate oral health from everything else, but today we're doing a deep dive into gingivostomatitis. It's an inflammatory condition that starts in the mouth, but as you'll see, it can have some surprisingly serious effects on the entire body.
We're going to walk through this just like you would in a clinical setting. We'll start by identifying the disease and figuring out the cause. From there, we'll get into specific treatment strategies. Then we're going to zoom out and look at the public health side of things, cover the really severe complications, and wrap it all up by putting our knowledge to the test with some quick case studies.
So, first things first, what are we actually talking about here? What does this condition look like? And how do we start to tell it apart from other things?
The most important thing to grasp is that this isn't just inflamed gums. That would be gingivitis. This is gingivostomatitis. The stoma part means it involves the entire oral mucous membrane. It's a much more widespread inflammation, and it usually kicks off with a primary infection, often viral, like herpes simplex virus. But as we'll see, bacteria can definitely be the main culprits too.
Okay, so right out of the gate, you have to start differentiating. On one hand, you might be dealing with herpetic gingivostomatitis. That's viral and it's extremely contagious. On the other hand, you could be looking at thrush or oropharyngeal candidiasis. And here's the key clinical pearl. Those characteristic white cottage cheese-like patches, they can be scraped away, revealing red, raw tissue underneath. That simple physical finding is a massive diagnostic clue.
So just how infectious is that primary herpetic form? Well, the source material had a pretty memorable way of putting it. It spreads faster than gossip in a hospital cafeteria. It's a funny line for sure, but it drives home a really serious point about just how rapidly this virus can tear through places like daycares, clinics, or hospitals.
So you've seen the patient, you have a strong clinical suspicion. But how do you prove it? How do you nail down the exact pathogen you're fighting? Well, that journey takes us from the bedside straight to the laboratory.
The lab workflow is really a four-step process. It all starts with getting a good sample, a meticulous swab from the lesion. Step 2 is a quick look under the microscope, which can give you immediate clues. Step 3 is the culture, where we try to grow the bug on specific nutrient augers. And for those really tricky or slow-growing organisms, we bring out the big guns, nucleic acid amplification tests, or NAATs, for a precise molecular ID.
And this is why that direct microscopy step is so valuable. If you put that swab on a slide and you see yeast and these branch-like structures called pseudohyphae, you've got a working diagnosis of Candida right then and there. It's a perfect example of a simple, rapid test giving you actionable information to get treatment started while you wait for the full culture results.
Okay, we found our bug. Now what? Now we treat. And this is where precision medicine really comes into play. You absolutely have to tailor the therapy to the specific pathogen to be effective and, just as importantly, to avoid promoting resistance. And if you need a stark reminder of why we can't just guess, look at this number. For Staphylococcus aureus, which can be an oral pathogen, the rate of resistance to standard penicillin is around 80%. 80. That one statistic makes it crystal clear why we do susceptibility testing. It isn't just an academic exercise, it is absolutely critical for successful patient outcomes.
So if you've confirmed a viral cause like herpes, these are your go-to agents. For most standard cases, oral valacyclovir does the trick. But if the infection is particularly severe or if your patient is immunocompromised, you'll want to go with intravenous acyclovir to guarantee you're getting enough drug into their system. For both, it's typically a short, focused course of 5 days.
Now, if the lab points to a bacterial cause, especially a mix of anaerobes from the mouth's normal flora, the strategy completely changes. We go with combination therapy. The benzyl penicillin handles a range of susceptible bacteria, but we add metronidazole specifically to crush the anaerobes, some of which can actually produce enzymes that protect other bacteria from the penicillin. It's a classic 1-2 punch, and the treatment course is longer, usually around 10 days.
And for our third category, fungal infections like Candidiasis, the approach really depends on the severity.
If it's a mild, localized case, a topical treatment like miconazole oral gel for about a week is often sufficient. But if the infection is extensive or the patient's immune system is weak, you have to escalate to a systemic drug like fluconazole to clear the infection, and that can take up to 2 weeks. Okay, treating the patient is one thing, but some of these pathogens have implications that go way beyond a single individual. This is where we have to think about public health, infection control, and our responsibility to report certain findings. So while you might not report gingivostomatitis, you absolutely have a duty to report some of its potential causes. If your lab workup identifies a serious pathogen like Corynebacterium diphtheriae, an invasive group A strep infection, or a cluster of MRSA cases, those are all notifiable conditions. It's our job to recognize when a simple mouth infection is actually the tip of a public health iceberg. Of course, the best medicine is always prevention, and it comes down to the fundamentals: meticulous hand hygiene and excellent oral hygiene. This is especially crucial for patients before and after dental procedures, or for those with dental hardware. Good hygiene helps prevent what we call a transient bacteremia, where oral bacteria catch a ride in the bloodstream to go set up shop somewhere else in the body.
And that brings us to a really critical and, frankly, scary part of our discussion. What happens when these oral infections aren't contained? What are the worst-case scenarios? This list is incredibly sobering. An untreated oral infection is not a minor issue. It can lead directly to bacteria in the blood, or bacteremia, and progress to sepsis, which is life-threatening organ failure. It can seed infections in bone, causing osteomyelitis, in joints, causing septic arthritis, or on the valves of the heart, causing endocarditis. And with certain toxin-producing bacteria, you can get horrific conditions like toxic shock syndrome or flesh-eating necrotizing fasciitis. The stakes are unbelievably high.
All right, we have covered a ton of ground. We have all the pieces of the puzzle, so now let's put it all into practice with a couple of quick clinical scenarios. Okay, first case up. You have a 4-year-old child who comes in with painful lesions all over their mouth. Your top suspicion is thrush, or oropharyngeal candidiasis. What specific finding from an oral swab, viewed under the microscope, would confirm your suspicion? Think back to that diagnostic slide. And if you said seeing pseudohyphae or budding yeast forms, you are absolutely correct. That is the classic microscopic picture for Candida, and it gives you the green light to confidently start targeted antifungal therapy. All right, one more for you. A 35-year-old patient who is immunocompromised presents with a really severe case of herpetic gingivostomatitis. What is the recommended first-line systemic antiviral treatment, and for how long would you give it? The correct answer is valacyclovir, or, more likely in this severe immunocompromised case, IV acyclovir. And the duration is key. It's a 5-day course. That is the standard of care for this clinical picture. So, to wrap everything up, let's leave with one final big picture thought. We've seen exactly how a seemingly localized infection in the mouth can seed devastating, life-threatening disease throughout the body. Does that knowledge fundamentally force us to reframe our view of the mouth, not as a separate entity, but as a primary gateway to a person's overall health? It's a powerful concept to carry into our daily practice. Thank you for joining me for this explainer.